Dr. Bill Hazel, and he's the Secretary of the Commonwealth Secretary of the Commonwealth.
Human Resources.
I'm running together.
I had nothing to do with appointments.
He's,
I'm glad of it.
we work pretty closely with him pretty much throughout the year, just particularly during session, and he's come and talked to our local members several times before. He's going to talk a little bit today from a state perspective on the Affordable Care Act, exchanges, Medicaid, and all that kind of stuff, I'd imagine. And I'll let you take it from there.
Okay, very good, very good. Well, thank you. First of all, I am not late. I'm early.
You're very early.
Now you can tell people, and they'll think that your credibility will be lost. But anyway, our challenge is Secretary of Health and Human Resources. Obviously, we've got the responsibility for dealing with healthcare reform, and all of its various pieces. And the thing I can sort of start with, and I just spoke to a small business group out the Weston, and I will tell you, we absolutely have to reform healthcare in the country. There's no two ways about it now. Not that we necessarily believe that what happened in across the Potomac Ocean was the ideal way to do it, but it is the law of the land now, and it would take an act of Congress to change that path. And since Congress only does big issues every once or twice a century, we think it's likely to be here for a while, and we have to live with it. And I think the key here is looking at the amount of we spend on healthcare in this country, $2.5 trillion annually, and that number was from a couple of years ago, 2009. It has gone up, and why that is important is if you look at we think there's a lot of waste in there, inefficiency, fraud, all of these pieces play into to what the cost is. And kind of the question would be is why is it important? Why is it important? And I think this is the answer to that. Does anybody know what percent of our gross domestic product in the United States is spent on health care?
18%.
Good. All right. All right. Now I'm going to challenge you. What country is second percent of GDP spent on health care? Since you were so smart and you're laughing at me and you're eating glasses piece, what country is second?
Great Britain.
Would you care to guess again?
No.
That's right, Switzerland. Switzerland's not an inexpensive country, is it? And they cover everybody. And you know what percent they spend? Probably not, but it's 11.5% of GDP. Now, an orthopedic surgeon says 18 minus 11. You have to take your shoes off for that, but I remember it's 6.5% of GDP. Does anybody know how much 6.5% of GDP is? I don't know if it's a big number, but I can tell you that there's a line item in the federal budget that's 3.5% of GDP. You know what that line item is? Our entire U.S. defense budget is 3.5% of GDP. And we are spending almost twice that in excess of Switzerland on health care. Now, and they're covering everybody. How do you explain that? I'm not even going to say justify it. How can you explain it? Are we that much better? Or is our health better or worse? How do you get it from here to there? And I think that's really the challenge, and it matters because when you are looking at our Medicaid budget at the state level, which in 2014 is going to be $9.5 billion. 2014 budget, $9.5 billion. It's just now topped over 1/5 of Virginia's budget. And when you're spending that much on Medicaid, what are you not spending on? Well, that's one thing, education, transportation, and these other things that we kind of like. So that really is the challenge in the public sector. And there was a time that being a recovering orthopedic surgeon, such as I am, I used to think 18%, that's great. You should spend more on healthcare. It's more people who needs a knee replaced, hip replaced, or ACL. I mean, it's a great thing to do. The problem you get into is that half of healthcare is paid for by us in the public sector. Half is paid for by the private sector through taxes, or the tax deductions that go to the public sector, but half of it's basically private sector. So a couple of years ago, I was down in Greenville, South Carolina at a meeting where a hospital system, it's a Von Scotia hospital down there, St. Francis in Greenville, South Carolina, was redesigning care for people with type 2 diabetes. They're going to have a world-class program in Greenville, South Carolina, to take care of people with type 2 diabetes, adult onset of diabetes. Anybody know why they were having those meetings? Think all the doctors got together when they came to the hospital and said, you know, we can do better? Does that happen in your localities? No? I can see your head shaking. It's not rattling yet, so that's a good thing. At least I can't hear it. The next option is, do you think the hospital board and powers that be were sitting there looking at their operating structure and say, you know, if we could do a little better job with these people, we'd save a lot of money and our bottom line would be better? You look like you're about to bite on that one, aren't you? That's not what happens. The reason is because in general, when you reduce costs, you're reducing revenues, the way we pay. You know, you all hire your painters by the hour, and you all hire us by the hour. And so, you know, when you start reducing the number of hours of service, it may be a better service, but you're losing your revenue with it, and that's a problem. So the reason this happened is there was a little company called Michelin. You know the Michelin man? I only resemble him, not him. Michelin has plants in 5 continents, right? And they're in Spartanburg, South Carolina, and they employ 22,000 people. Now, who would like a Michelin plant? Now, if anybody's from Arlington and Alexandria and Fairfax, I know you won't, but the rest of you might be interested in that. Now, 22,000 people making tires for a living, right? And Michelin is saying, okay, you guys need to fix type 2 diabetes. And why do you think they came to the community and said, you need to fix that? First of all, 1,750 of our employees have type 2 diabetes, which is an entirely preventable condition. That means the system isn't working. And the second problem is that our insurance rates are going up. You know, we're paying for these people, and they're making tires for a living, right? And you know, we're doing everything good companies are doing. We're charging them more for their insurance and higher co-payments and higher deductibles, so they have skin in the game. And guess what? Same problem we have as a taxpayer. You can't pay people enough when they're making tires for a living for them to leave food on the table, roofs to sleep under, transportation, and education so their kids don't grow up making tires for a living. It just can't happen the way we're paying people. So it becomes a jobs issue if we can't get health care under control. And so maybe I can get this together the right way. So we look at the whole issue of how we do a farm, and we'll come back a little bit to that. But the PPACA basically does 4 things. The first, it said that everybody up to 138% of the federal poverty level would be eligible for Medicaid, and states had to expand their Medicaid programs. Now, the Supreme Court decided that that was unconstitutional because it was coercive to states, a violation of states' rights, so that expansion is optional. And that is the big thing that we're discussing in healthcare right now. Do we expand Medicaid in Virginia or not? Come back to that. The second piece of it was that if you were an employer, you had to continue to cover your employees. If your employer greater than 50, that is. If your employer less than 50 full-time equivalents, then as determined by the IRS, our favorite agency, if you have less than 50, and this is impacting a lot of you all because you've got people who are part-timers, and if you're over 30 hours, then you get counted towards that benefit. And so you know, if you're over 50 and you get your employment, that's the one where if you like your insurance, you will continue to have it. It won't change. It won't cost a dime more. Remember that? Okay, that's that piece. Then the third piece is they're going to create these things called exchanges, and the name has now been changed. They're called marketplaces. And Virginia will have a federally facilitated marketplace. And what will happen is people will go to an electronic portal, and they will sign up for a benefit. And basically, if they're eligible for Medicaid, they get routed to Medicaid. If they are eligible for the exchange and they happen to go to the exchange portal, they'll go in and they will fill out a 71-question form and determine whether they get an advance of the tax credit that will be paid to the insurance company to support them buying insurance. Now, what I'm told is that that will be available in October. The feds still think that's on time. It won't be pretty, but it will be there. And we know that in Virginia, what we did is we decided we weren't going to build our own exchange. And frankly, I'm glad we did. I'm the happiest guy in the world we did because I didn't have to help build it. You know, right now, I'll give you an example. We have created this consumer portal for all of our social service, well, not all, but 5 of our social service programs: Medicaid, energy assistance, child care, SNAP, and TANF. We have just now, over 30% of Virginians are now using that portal to do an electronic assessment for benefits, which is, you know, I think a very useful thing. The issue we have is that as individuals come in to get their Medicaid, if they don't qualify, we're supposed to be able to have them then complete the format for the tax credits and send it to the feds, but they've already told us they're not going to be ready in October. So now we're scrambling around trying to figure out how we do with all these electronic applications, and how do we store them, and then how do we get them sent up when we're supposed to. It's just not there yet. So there are a lot of things that we still don't know about how that's going to work. So, but there will be something there by fall. Now, our issue that we are trying to deal with most aggressively right now is the issue of Medicaid. As of this week, we have 980-some thousand Virginians insured by Medicaid. This is, you know, where they live. You all will recognize a lot of this. South side, southwest, western of the valley, peninsulas, eastern shore, particularly heavily populated. If we don't expand Medicaid, what happens is these individuals are still mandated to buy insurance. The individual mandate did not go away. Now, what the administration has said, they're not going to enforce it. I don't know what enforcing it means, but I don't think anybody does quite yet know what enforcement of that means. But so we will have a situation where for people above 100% of the federal poverty level, from 100 to 400% of the federal poverty level, you'll be eligible for benefits in the marketplace. Below 100%, you won't. So that's the challenge that we're going to have. We're going to have this gap for these folks here. A couple of things about the uninsured Virginians, and important to know there's a general perception that they don't work. You hear a lot of comments about who they are. 41% of the families have a full-time worker. There are part-time workers, no working adults, and some of those aren't working because of disabilities, or they got laid off and there's no jobs. They sometimes have trouble getting it. Some of these folks are unemployable by virtue of criminal records, things like that along the way that have become a problem. So I've talked to you a little bit about the components, the requirement of insurance, the health benefit exchange, the marketplace, Medicaid expansion, and then we're going to talk a little bit about innovation. There is money for innovation there. Now, for Virginia, what we decided to do is to let the feds build the exchange. We kept their 5 pieces to an exchange. I'll run through those, but the one that we kept is the plan management. So the exchange has to do eligibility, receive the applications, it has to determine the eligibility, has to enroll people in the plan, do customer assistance, and then it has to manage them. This was more than we felt that we could do well in the time. I think had we been able to start probably last May or June and had everything we needed to know, I think we would have had a shot at getting it. But frankly, and the reason I finally said no, we shouldn't do it is because I just think we couldn't do it with what we did. Long and short of it is the General Assembly did agree to leave the plan management with our Bureau of Insurance. We know that 9 companies, or there are 9 plans that have applied to participate in the individual exchange, 7 in the shop exchange. Okay. Now that doesn't mean there are going to be 9 choices in every area, because, for instance, an Anthem plan is Innovation Care in Northern Virginia. It's Majestic Care around Carilion, and so there are some in multiple areas. But we do think there's going to be coverage for individuals in the individual market this year. We don't know what the rates are going to be yet, which is the other piece of that. we suspect that there will be some competing factors going on in states that have traditionally eliminated rating, or you've had higher insurance premiums for a long time. We didn't do that. We've had the ability to rate by age and underwrite based on health conditions. So when those go away, we would expect to see some increases in premiums. I think it's logical to expect that. So it will not be a panacea. Now the other half of that is individuals getting insurance will be eligible for the subsidies between 100% and 400%, and I think this gives you a little bit more detail, and I think you have that as to how that will work out. I think the real concern is that the folks at the lower levels, under say 200%, even with the subsidies, are still going to have a hard time affording an insurance product. Who are those people that we're looking at in Medicaid? Currently, this is another thing to know about Medicaid, we cover children, and we cover the elderly and disabled up to 80% of the federal poverty level. That federal poverty level for a family of four is about $24,000. Okay, so we cover the 80% of there. We cover beyond this for children, it's up to about 200%, and we cover pregnant women. And we cover what we call caretaker adults. These are parents of these children who are covered. That's it. So we have most adults, childless or with kids, and elderly and disabled babies who do not get Medicaid in Virginia. So if there is an expansion, these are the folks that will come into Medicaid. We think there are about 450 or 460,000 out there that would fall into this category of optional expansion. So we have 980 some today. We add 450 to the rolls. As I mentioned, we're already at 20% of the budget. Who wants that problem? Now, the other half of that is, the feds say, not a problem, because we're going to subsidize these newly eligible. We're going to pay 100% of the freight for the first 3 years, the 90-foot, right on down to 90%, okay? Now, this starts January 1st, whether Virginia expands or not. So if Virginia doesn't expand until July, we've lost a half a year. There's no catching that up on the back end. That's in statute. It starts in January. Anything that doesn't come in is gone in terms of Virginia budget. The real challenge, I think, that the General Assembly is one of us wrestling with is, and you all would all probably resemble this, is we don't like to raise taxes ourselves to pay for other people's promises. And where I think the General Assembly is the feds have promised this, but they're very afraid that this is going to go away. I mean, we've been dealing with sequestration this year, those potential problems. We've got BRAC closings coming up that could impact Virginia, and there's a lot of concern about the ability of Virginia to fill in the gaps without raising taxes. And I think the transportation bill for a lot of folks has been a chastening experience. You've got people like Joe May and Tom Rust up in Northern Virginia who voted for it, who are now, you know, Joe is probably in his first real fight in a long time. It's a Republican primary. So what they come back with, having learned from raising taxes, I think is going to play a role in what they decide to do here. What we have done is we've tried to estimate the costs of the Affordable Care Act, and whether we do anything or not, there are savings to Virginia. Now, for instance, we've already benefited from drug rebates that have come back to us. I think it was about $30 million this year came back to us. That really helped us with the whole. In 14, well, what I can tell you, let me do this on another slide. This is the CHIP program for kids. Kids who are eligible up to 100%, or in our current program, would become eligible out of CHIP, would become eligible for Medicaid. The CHIP program itself, we pay about 75% of. When they go to Medicaid, they'll be 100% federally funded for the first 3 years. So that saves Virginia money in the budget. It's all the same taxpayers, but it's federal money instead of state money. So we have a couple of things like that. We would have some coverage eliminated, and When we first started running these numbers back in 2010, we were looking at 387,000 people and a 10-year or 12-year cost of $2.2 billion. We think now that the net cost, because of things we learned over time, that if you do the expansion, we will save $192 billion between now and 2022 on behavioral health by not using general fund dollars. These people will be insured through Medicaid, 100% federal funds, $190 billion. Prisons, inpatient hospital savings for prisoners. When you leave the prison overnight, you'll be eligible for Medicaid. That's another $192 million between now and 2022. That becomes 100% federal money as opposed to 100% state money. There's some indigent care savings that go in here. So there are a couple different ways, and I will tell you that's just prison numbers that I just gave you. I don't know what happens with jails. Jails, they're eligible for Medicaid also. So if you've got people in jails and they're on Medicaid, that's going to be a cost saving for localities. Taxpayers still pay for it. It's still paid for some way, but it's not in your budget anymore when they go out. So what happens here is in these first years, this is pre-14, we see the impact of the mandatory provisions. These are the savings that we already took in the budget this year, okay? Then we go out for a number of years, and then as the goes down to 92 and 90%, Virginia ends up picking up money in those out years. If we do the optional, and I will tell you the caveat to this is that we don't expect everybody to sign up. The national number being used is 68% of eligibles will sign up. I don't know who declared that. I don't know how accurate it is, but that's the number that we're using around the country right now. If we expand, this is just the optional piece. What we end up doing is we save Virginia a lot of money early on. This is the behavioral health, prisons, drug rebates, and then over time, as the federal share goes down, Virginia picks up a bigger piece of it. And I've already gone through this. So this is the net. So you can see Virginia, if we expand, gets savings out there, and it's 68%, those caveats. We save out through about 2018, and then we start expanding now. The area under this curve is $137 million more than the area under that curve. So it means that Virginia, so when you read in the paper, which you might have done, it'll cost Virginia $137 million to expand Medicaid. That means if 68% of people sign up and no more, and all the other assumptions are the same, and the federal match is there, and we save every penny of this. Have you seen a General Assembly save every penny of that for that length of time to offset that increase? But that is in the budget bill, a savings to account for that. The fiscal impact, obviously, is for the amount that Virginia sees. You see the savings, it crosses over in 18, and we spend, what, $300–400 million more. We get $3.7 billion of federal funding for that. And I think the real question here is, if we don't take this money, where is it going to go? Is it going to turn into savings, or is that wishful thinking? We've done some calculations. There are 21 separate fundraising provisions in the PPACA, offsets for costs that went into effect or are going into effect. The sum total of those is that we believe will impact Virginians to the tune of about $26.3 billion between now and 22. We Virginians collectively are going to put $23 billion on a barge and send it across the Potomac Ocean to Washington, no matter what we do. Okay, that's something important to know. We think that we'll get about $6.6 billion back in subsidies, premium assistance through the marketplace. So and that's going to happen no matter what we do. So 26 minus 6, I mean, bear with me, that's $20 billion net outflow. If we expand Medicaid and the numbers hold, we bring back an additional 23. So the net taxpayer cost to the federal budget is about $3.5 billion. Now, there's one caveat to that. Already in the PPACA there is a plan to cut hospital reimbursements about $5 billion over that same time period. So the hospitals, when they come talk to you, they're going to tell you we're losing revenues, and they are. They're changing the way they're paying hospitals, or trying to drive the costs down, or there. And if you think about it, it makes sense. If you're insuring more people, there's less indigent care. We got more people in Medicaid. There are other streams of revenue that were supposed to counter that. If we don't take advantage of those, then it's a net loss. So that's what you'll be hearing from your hospital folks. And who here has already heard from their hospital folks? You have it? I'm amazed. So Virginia set up something called the Medicaid Innovation and Reform Commission. There are 5 senators and 5 delegates on it. It meets for the first time Monday of the 17th of June down here. The 5 senators are Senators Stosh, Watkins, Hanger, Howell, and something Bowden. You know who the 5th one is? They're all in the Finance Committee. I'll think of them. The 5 senators believe that they appropriated a sum sufficient money to expand Medicaid, given that certain conditions on Medicaid reform are met. And they believe what their job is they're going to have to be sure that we are getting the Medicaid reforms in place so that they can release those monies. The 5 delegates are delegates Landis, O'Bannon, Massey, Sherwood, and Joanna. They believe that they don't even talk about releasing money until we've done the reform. So there's a real difference in the mindset between the 2 groups. And I expect that first meeting on the 17th is going to be one of doing some organizing. Who's running the meeting? You know, what's the agenda going to be? They've asked us to prepare Medicaid 101. Let's go back to 1964, talk about why we have Medicaid, who's covered, who's not, why the expenses have crept up over time, numbers, where we're doing better jobs with cost effectiveness and not. So we've got, it's going to be a very interesting process. And the only thing I'm pretty sure of is we won't have an answer until after the election, if we have one then. And if we wait that long, and they did decide to expand, it would probably push the ability of DMAS to actually expand. There's no button you push that can do it immediately. It would probably push it back into late next year, so we'd miss most of that first year of benefit if we're on the trajectory we're on. They told us to look at 3 phases of reform. Phase 1 down here are things that we are doing currently now. Phase 2 are some things that we are working on that will be implemented in July, and so we're trying to get some negotiation with the feds to get some flexibility in our Medicaid program. Phase 3 is to really get us into the long-term care population. And you have to remember that 30% of the Medicaid population spends 70% of the money. Okay, the other 70% spends only 30%, but these 30% are your folks who are in long-term care, IV and DD waiver programs, the home and community-based waiver programs, and there are folks who are, we would call the healthy disabled, for want of a better term. They're people who are age-blind and disabled, but who aren't in nursing homes. They're in the community. They cost about $10,000 a piece a year. The nursing home long-term care folks are $48,000 per person per year. The adults that we cover are about $5,000 per year, and kids are about $2,800 per year per person. So a couple things that have happened. We've been working with CMS. Marilyn Taverner, who was secretary before me, is now the administrator for CMS, and she's been very, very helpful. We've been able to talk about a dual eligible demonstration project, and we now have a memorandum of understanding with the feds. And what this is this is where we, through Medicaid, pay the Medicare premiums. And what the reason that we need to align incentives is today, we believe we could spend up to $50 million a year managing the care better and getting savings for the taxpayer. But all the savings would accrue to the Medicare program in the federal budget, and we don't get our money back for that. So we're the 6th state to reach an agreement about shared savings. So if we save, we can get back enough money, hopefully, to pay the cost of doing that. Now, if you, for instance, if you all were going to do all this work for us, and we took all the money, how would you feel about that? Like you do every other day, right? It's called social services. Is that what you're thinking now? You're going to get me. But that's the problem we're into, and it's a huge, huge number. So, you know, we now have that agreement that was announced 2 weeks ago. We're pleased about it. We've got a significant emphasis around program integrity. There are a lot of folks who think that the problem is largely fraud and abuse. You know, we do almost 1,550 edits on every claim before they're paid to ensure that they're appropriately paid. Our payment error rate is historically under 1% that we can identify. We work with the AG's office and the Medicaid Fraud Control Unit regularly to try to catch the bad guys. And the bad guys are out there. There's no doubt about it. There's some, but I think that the thoughts that we can get enough out of fraud and abuse to solve the problem are probably misguided. We are putting all of our 12,000 kids in Medicare, Medicaid managed care program, hopefully by the end of the year. We thought we were going to be able to do this by October, but for some reason we're finding that the addresses in our social service system aren't actually addresses where these kids live. And if we don't know where they live, we don't know what lands to give them. So we've run into a little bit of a delay there, but that's coming. Some of you have already probably heard the complaints about our eligibility and enrollment system. I can come back a little bit about that, but I mentioned that we now are getting about 30% participation in online enrollment. And this is critical. The last few years, we haven't been able to give your staff money for social service for eligibility determinations. And you've seen, I think 2 years ago, we did 1.2 million Medicaid applications. We did 1.1 million SNAP applications. They're all roughly the same folks, or there's at least significant overlap. But what we were able to do was to work with the feds, and we got 90% federal funding, administrative match through Medicaid, to help build an eligibility system. The only way it works is if it's used. And that involves some organizational change management, the way you handle and process things differently. And we are working with your social service agencies now to have them utilize this. Why this is important is because if there's a Medicaid expansion and there are another 450,000 people coming in for applications, who is going to do that? Do you all have the staff? I mean, and so we were thinking ahead. We didn't do this through exchange planning ahead of time. We did it with 90/10 Medicaid money with the idea, and we were the first state to get an agreement with the Office of Management and Budget to multi-purpose this. So we use Medicaid money to build the eligibility and enrollment system. We are, and we can use it for other purposes as long as they pay their fair share. So that is the way. So when you hear them saying, well, there are going to be 68,000 famous kids that now we're going to have to manage, well, hopefully you'll have 300,000 off your rolls by going into the automated portal. And that's the goal. We're working with our Wounded Warrior programs. Veterans get very good benefits through the VA, and the federal funding is through the VA for that, and we want them to get those. And then we've just awarded a behavioral health service agreement. Many of you all will hear some concerns about this because this will impact your CSVs as time goes, and we can talk about it. The next phase is really what we're trying to get to with programs and the changes, and it deals more with the expansion population. There is a federal law, a statute. We can't do anything about it. They can't waive it. Individuals below 100% of the federal poverty level are limited in how much they can contribute economically to their care. So when you hear about cost shifting or cost sharing, skin in the game, there's some limits that CMS can't waive. It would take an act of Congress. Did I mention how hard that was? I don't see that changing anytime soon. So we're looking, how do you engage a consumer who doesn't have money? I mean, we know if you're in Roanoke and looked at their regional assessment, their gap assessment, you get quotes from people through a one page or 3 of them. Basically, we go to the emergency room because they're always open, and nobody ever tries to collect from us because, and if they take us to bankruptcy, what difference does it make? So we're looking at things like, can you give people a card that's worth $200 and say, this is what you use for your co-payments and deductibles, and the better, if you go to the emergency room, you use them a lot faster than if you go to the primary care doctor. So we're really trying to get into some innovations like that. But we are asking CMS as part of our agreement to okay some parameters for pilots. We'd like to take people who are high utilizers of medical care and perhaps restrict the network of providers they're able to see. They still get Medicaid, they still get the coverage, but we're going to be more assertive or even aggressive about managing that care. So there are some trades here that we're trying to make because there's no silver bullet here. I mean, you hear about Medicaid reform in Louisiana. Louisiana is doing what Virginia did in 1997. We can't do it again, we did it. So we have to go through a very involved management program. We're looking at quality payments incentives, standardization of administrative processes to help providers. We're asking each of our plans in the new contract in July, each of our plans is going to have to do 2 innovations. It's got a Chinese menu sort of thing where they get to pick and choose, and we want them to do 2 innovative projects largely around medical homes. So, but what we're trying to use is push the insurers in the Medicaid section to make changes that will change provider behaviors. That goes to that 11.5%. If we don't change the delivery system, we're never going to get a handle on these costs. And it's not about who pays for the insurance and who gets it. It's about whether we can make the delivery more cost effective. And so we're trying to align the Medicaid with what we're asking for the 100,000 state employees, and we're working with the chamber. They're having a conference tomorrow. We're working to try to align what we're asking for, so we're driving reform through the system. And then I mentioned, we'll go through there. Phase 3 is the long-term care, which hopefully will build on the dual eligible projects. Objectives, obviously, better service delivery, less administrative burden, and increased beneficiary engagement. We do think that those savings in those first 5 years, if you're going to save it, you got to take a little bit of it and invest in bending that cost curve in the out years, because if you're a senator sitting there today and you're looking at having to find $300 million more for Medicaid 8 years from now, you know you're going to be there in 8 years. I mean, it's just the nature of the beast. You know you're going to be there, and you don't want to have to find that. So you've got to reinvest in bending that cost curve. Talking about the MERT, Senator Lucas is the 5th senator, the one whose name I couldn't speak of just a minute ago. One thing that you will hear a lot about from your agencies is the eligibility determination. There is something called MAGI, maximally adjusted gross income, which will be the new methodology for determining eligibility for Medicaid. Now, this was designed to simplify and streamline eligibility, so they created a new category and didn't eliminate any of the old ones. But starting in October, when people come in to apply as new applications or renewals, we have to use this new methodology. It is not just the formula, it also means that people have to be able to apply in person, by phone, by fax, by email, and there has to be call center support. Now, are you all prepared in your localities to do all of those things? You're not? Did nobody tell you? Well, good. We're doing it for you. That eligibility system is designed to support this, and we are creating a call center through Medicaid right now. We'll take the current call center that we're using for Famous, and we will be expanding that for the purpose of supporting this. Now, here's the hard question. If we have a common eligibility system and we're automating most of these things, and we have a call center for Medicaid, do you folks want to start into the discussion before we make it permanent about whether we also want to support the other applications online through a centralized call center, or do we want to continue to do it through your locals? The reason that's important is Medicaid gives you all about $100 million a year for eligibility determination. And we do believe that by centralizing that, we can take 20 or 30 million of the cost out. The problem is that will likely come out of what we transfer to you. Save the taxpayers money, but it'll create some difficulty. So that's something that we're going to have to think about, because they're all over me, Bill, you gotta put out an RFP for this call center going into the future. I said, Governor, unless we know what we wanna buy permanently, I shouldn't get us committed to anything that we're then gonna have to undo and change. So we need to accelerate that discussion about call centers. But basically, what will happen is every application we're going to have to ping against what's called the federal hub, which will have individual citizenship data. You know, we'll ping against IRS, and we'll ping against Social Security to ensure that to get a better, this is the effort to be more accurate at determining eligibility, reducing fraud and abuse, and so forth. I've mentioned EHHR, the portal. We have used the 90% Medicaid funding for this. This is something, if there are any would-be geeks in it, we're building something called service-oriented architecture using the MITA, Medicaid Information Technology Architecture, 90% federal funds. We have purchased we built the portal based on the child care solution that you have now. We're building a case management system, the EDM, we have rules engines, and what we would like to be doing, and I know with Harrisonburg and Fairfax, we're actually now beginning to talk to the locals. Can you all ride these rails for your own local work? Could VITA essentially, I mean, you've heard VITA is a four-letter word. I'm sure all of you have heard that. VITA's been really good the last few years working with us on this project, and the question is when you have your own rules and so forth, can we share this system to make it more cost-effective for all of us? It's something that we want to talk about doing because we need to be planning the scalability of this even earlier. Medicaid technology enhancements. I will tell you that the last thing is we created something called the Virginia Center for Health Innovation, and it lives at the Chamber of Commerce. And that was done because we had heard that health reform in Virginia was a politically charged issue, and we didn't know what. It's okay to smile at that. So it has been, but we thought that if it was out of the chamber and functioning quasi-independently, we would have more flexibility to pursue funding and so forth. And so we've created six work groups in that. One group is over there at 1 o'clock, 1:30 is about consumer engagement. How do you use the insurance, the financing tool to get people to engage in their own health and their own health care, get to the right service? An example of this, the common thought or the term now is VBID, value-based insurance design. For example, I'm not likely to have breast cancer, but if your mother had breast cancer, your sister had breast cancer, who's next? So why would there be a standard $1,000 deductible between you and a screening procedure that would reduce your morbidity, reduce your mortality, and lower the cost of care? I mean, those are things that we can now handle. In my family, it's colon cancer, so up until the New York Times article this week on overuse of colonoscopies, I have colonoscopies. Well, we don't line up for colonoscopies, so to put additional financial barriers between people and something that reduces morbidity and mortality and lowers the cost makes no sense. So we have better ability to do that now. So we're looking at insurance design. In fact, we now are offering through the State Employee Health Plan. Some of you may have seen Alex, the online decision-making tool, and we are offering more of a consumer-engaged health insurance program, trying to bring this to Medicaid as well. The yellow box, improving transparency and value. Mom asked me, I'm an orthopedic surgeon, recovering now for a little over 3 years, and I said, I've met them, I like them, they speak well, they look good, they walk around the operating room like they know what they're doing, but I have no idea unless I've been in the room with them, and that's my own judgment. I have nothing to compare with. And how do we know these things? So General Assembly created the all-payer claims database, so we're trying to, I know it makes me choked up too. So we created the all-payer claims database, and now we're looking at how do we get information out of that that helps us redesign the system. 2 work groups, 6 o'clock and the 7:30, 8 o'clock box, are around delivery reform. You all know the term patient-centered medical care. You've heard that term. Currently you pay your family doctor like you pay your painter by the visit, by the hour. And what a family patient centered medical home does is say, we're going to change that. For if your doctor, you've got 500 patients, and we're going to pay you per member per month, and you're going to have an electronic record, and you're going to have 24/7 availability. Either you or someone can cover who has access to that record. And where that exists, ER reduction goes down 40%. Been shown over and over again. That call after hours to get medication refills, I'm sorry, but we don't prescribe you that medication. You know, you can't have more Percocet after hours. Those types of things come in. They, instead of just paying for the end of when you come in and you're sick, what you're doing is you're saying, if you're a diabetic, you keep your hemoglobin A1Cs within a certain range. If you have cholesterol, you're testing and educating your patients, so we pay for something different. That works in primary care. The question is suppose you have heart disease that's beyond what a family doctor should do. Can we create, in congestive heart failure, for instance, is a big problem for hospital readmissions. People go out of the hospital, don't take their medicine, lungs fill up with fluid, and they're back in again. So can we create different payment mechanisms to do that? So what we're doing with these is we're trying to create a narrative around reform where we can apply for some of the federal innovation money that's out there. We're hoping to get up to about $60 million over 3 years. We'll have to have the applications in later this year. So this is moving it towards specialty care. And then the orange box is how do we deal with mental health issues? We know that we don't have a real good track record in primary care dealing with mental health issues. It's hard. We don't have the numbers of providers, so can we make the medical home model work in mental health arena? And suppose your primary issue is mental health, can that become your primary home so you're not going to this doctor and this one at the same time? And a couple of CSBs are working with us on that. We're looking at workforce, clearly a lot of areas of shortage of workforce. And then the top one is a project that I hope will work out, but we call it pre-C to pre-K. You know, we're all concerned about kids learning in school. You know, everybody wants kids to read at third grade level, grade level, right? It's the key to a successful future. So we spend all this time, you know, trying to get them pre-ready for pre-K and all these programs. And the question is are we missing something? What happens to kids who, you know, for prenatal reasons, we're seeing, you know, we have a high rate of prematurity in Virginia, high rate of infant mortality in Virginia. We're seeing increasing numbers of Part C kids. These are kids that have intellectual and developmental disabilities diagnosed at age 2. We're seeing problems with pre-K readiness, and what we want to do is set up a test really to see if being more aggressive, even with Medicaid, by the time women get into prenatal care, it's in the 3rd trimester. If you've been smoking that whole time, the birth weight's going to be lower. The brain development's not going to be there. So the question is can we do some things at targeted populations to change the trajectory, the life trajectory for these kids, and by using some of these medical home techniques. So we're looking into that, and these we're going to try to weave together to get the federal grants. So lots going on in healthcare, and I think it's going to be a little bit rough for a while, but I think, you know, we are really aggressively working to try to improve the value of our system for the public and private sector. With that, I'm happy to take questions if I haven't worn you out.
So you're going to get all this done in the next 6 months?
We're going to have a good bit of it done. Well, I think most of the Medicaid stuff will be either done or irreversibly underway. Now, whether that will satisfy the needs of the MERC, I don't know. I suspect those goalposts will move a couple of times before we get there. The innovation grant should be in. I'd hope it would be accepted by the time we leave. EHHR, the MAGI, some people call it MAGI, but since I'm yet to be convinced it's wise, I call it MAGI. MAGI will be operational, maybe not October 1, but shortly thereafter. So I'm pretty comfortable we'll leave it a little better.